Greetings, everyone, and welcome to today's lesson on blunt abdominal trauma. So, let's get started. So, this is really true. There are so many different organs in the belly, and given enough force, any one of them can pop, or medically referred to as perforate. We need to know where everything is located in order to help us figure out all the possible injuries that could occur. So, as always, we want to get a good history, right? We want to focus on the mechanism of injury. Once we have that, then we can focus on the damage. We want to basically determine if our solid organs are injured or if our hollow organs are injured. How that force has impacted the abdomen is going to have a direct effect on the severity of the damage, and which organ is injured is going to help us determine the severity of the blood loss. So when assessing our blunt abdominal traumas, it's just like all our other traumas. Focus on your ABCs first, right? Airway, breathing, circulation, that's our starting point. As with any abdominal assessment, nothing's different here, guys. It's inspection, auscultation, palpation, and percussion. In that order. Don't go mashing on the guy's belly before you look at it. There are some really specific signs when we deal with abdominal trauma that you can be aware of. So there's Cullen sign, and Cullen sign is the bruising around the umbilicus or the belly button. That's indicative of some intraperitoneal hemorrhaging. It can actually also lead us to injuries of the pancreas, or in our female victims, could be a sign of fallopian tube injuries. Then we have Gray Turner sign. Gray Turner sign is bruising on the flanks, one or the other, doesn't have to be both. It's a sign of retroperitoneal bleeding, a sign of a kidney injury, so you want to look for that. And then there's Care's sign, and I could be pronouncing that wrong, but I believe it's Care's sign. That is that referred pain in the left shoulder, the tip of the left shoulder. When it comes to abdominal trauma, pain on the left shoulder is usually a sign of a splenic injury, like a ruptured spleen. And the reason that happens, you know, why? Well, if you got hurt in the belly, why does his shoulder hurt? Well, I'll tell you guys. Basically, when you have that splenic injury, it's irritating the diaphragm and specifically the phrenic nerve, which travels all the way up to the shoulder. So when you have that phrenic nerve innervation, you're going to have that referred pain to the left shoulder, and think about splenic injury. Now, of course, with our bleeding concerns, we want to keep on our vital signs. We want to keep an eye on our blood pressures. As always, with traumas, first blood pressure, guys, always manual. Always get that manual BP first. In addition to trending our vital signs, we want to get our radiology involved. Now, a nice tool that we have in the most EDs is something called the FAST exam, which is Focused Assessment and Sonography in Trauma. And what that is, it's basically a bedside ultrasound that's going to help us see if there's blood in the belly, which, as we know, blood in the belly, bad thing, right? Good. So, I also want to talk about one more thing here, and that is the DPL, which stands for Diagnostic Peritoneal Lavage. It's a tool that used to be kind of a standard, and we've gotten away from it. And what this is a incision is made in the belly, and a catheter is inserted. The goal is to see what comes out. It's kind of like when you put a chest tube in. Similar concept as you're putting a catheter into the belly, and if anything comes out, you know that there's fluid in the belly. If nothing comes out, then the lavage takes place. You instill normal saline into the belly, then drain that fluid out and see what you get. It could be blood tinged. It could be soaked with gastric contents. You want to see what's coming out of the belly. It's going to help you diagnose if they're bleeding, if there's a perforation. DPLs are done a lot less these days because the FAST exam has taken the place. Why cut a guy open and jam something in his belly when I can just take a picture right at the bedside and get the same results, and sometimes these days better results. So I mentioned DPL because some places are still using it, but understand that it's not used as much, and you may actually never see it these days. FAST exam has taken place. We want to get an idea of just how much our guy's bleeding, right? So we're going to look for some visible signs. Obvious sign of bleeding is that abdominal distension. If his belly's getting rounder and rounder, there's definitely something building behind it. Also, keep an eye out for the seatbelt sign. The seatbelt sign, for those who don't know, if this is our guy, this is going to be a horrible drawing. I apologize greatly to any actual artists out there, but there's our guy. He's sitting down, and he's got his seatbelt going across him. Also a terrible seatbelt, but you guys get the idea, right? So this is a general seatbelt. If he comes in and you see red marks going across his chest or across his belly, that is the seatbelt sign. And the reason we got to keep an eye out for that is if you think about the force required to make a mark from your seatbelt, maybe you want to think that something's going on behind it. that being said, if they've got a positive seat, this is a positive seatbelt sign, right? If they've also got that, they're probably going to have some pain. We talked about that referred pain, but they're going to have pain elsewhere. We want to know what kind of pain. Is it dull? Is it sharp? Is it in the front? What quadrant is it in? Is it, God forbid, tearing? If anybody ever says they have a tearing pain to their chest or their belly, it's usually a sign of an aortic injury. And really pay attention to that if somebody says the word tearing pain. The fact of the matter is, if the guy's conscious, a conscious patient is a fountain of information if we're just asking the right questions. By the way, if we're moving down a little bit, you want to look for blood at the urinary meatus, basically blood coming out of the penis or out of the vagina. This is a bad sign. It usually means there's an injury to something above that point, right? So the bladder, the kidneys, the urinary tract. Blood at the urinary meatus is a sign of a much more severe problem. Whatever the case may be, it doesn't matter where that injury is. Do not put a Foley in these patients. If there's blood coming out, don't put anything in. I can't stress that enough. Another way to check for that bleeding is auscultate, percuss, listen for that resonance or that hyperresonance or that dullness, and like we said, get your radiology friends involved. For all suspected traumas, you got to anticipate the need for blood. These guys are bleeding, well, usually. So this is where we're going to bring in those massive transfusion protocols, that MTP. What your facility calls it may be different. The idea is getting a lot of blood to the bedside very quickly to get into your patient. As we're giving this blood, keep an eye on his status. Is his blood pressure continuing to go down? Do we need to give more blood? Do we need to give fluids? Do we need to give pressors? These are all things that are going to become very important as we're treating our guy. We always want to stay alert for signs of what we call an acute abdomen. And what that is, that's basically this kind of sudden severe pain and discomfort to really any part of the abdomen. It's usually diffuse. It's very hard to localize. And it's due to that peritoneal irritation on the inside. It usually indicates that there's some sort of severe bleeding, possibly a perforation. If the guy's showing signs like this, he probably needs surgery. And like I said on the last side, if we suspect those bladder or urinary tract injuries, we see that blood, no Foleys. When it comes to the liver, liver injuries are graded 1 to 5. 1 is the most minor, like a small lac. You're not really going to do much. 5 is bad. Basically, the liver has exploded. Really bad. OR time. Get those guys to surgery. If they have those low-grade injuries like 1, 2, 3, we're probably just going to admit them and monitor them. Some abdominal exams, and maybe some serial blood work. If they're unstable, like they're bleeding out, this is when they got to go to the OR and someone needs to pack the liver. I'm sure you guys have heard that term before. These are those high-grade liver lacerations, those grade 5. We all know how to stop external bleeding, right? Direct pressure. It's the same for the liver. Packing the liver is basically putting pressure on those lacs by the surgeon until another guy can sew them up and stop that bleeding. When it comes to splenic injuries, the trend, for the most part, they're graded similar, 1 to 5, and the trend is towards that non-op management. Serial exams, serial blood work. This is for those low-grade injuries. If there is a concurrent injury or you're pretty sure his spleen has exploded, obviously he's going to the OR. You got to take that out. Now, the interesting thing is because the spleen plays such a role in infection fighting, if we take it out, that risk for like life-threatening infection goes up. So because of this, when it comes to discharging these patients, we have to make sure they get certain vaccines, and they have to be on time. So pneumovax, flu vaccines, meningitis vaccines, they're on a schedule, and they need to be given on that schedule and shouldn't be missed. So with splenectomies, it's really important that we do some patient education with these patients about their vaccinations and their schedules. The pancreas. Well, the pancreas is really small, right? It's rarely the only thing injured. If the pancreas is injured, we should assume that something else is too. A pancreas injury, it's usually injured because it got squished by something. It could be a car accident, sports injuries, anything that's going to cause compression to the abdomen, as opposed to just like a hit with a bat. These guys probably got squished in something. MVCs are most common, motor vehicle collisions. As with most non-lethal injuries, the trend here is non-op. You're going to rest the bowel, meaning don't give them any foods or fluids. You're going to do some serial CT scans. You want to keep out for signs and symptoms of infection, and just kind of keep an eye on these guys. With kidney injuries, you want to think of the mechanism, right? So if someone was hit in the back or in the flank with a bat, or they were tackled from the side in a football game and they like got that shoulder pad hit to the back. All of those could probably be kidney injuries. Most kidney injuries are non-surgical, about 90% or so. If we suspect more severe injury, or if we're unsure of the course of action, well, then we got to get the experts, call in your nephrology consults. So bowel perforations. Well, a perforation is, well, it's a hole. In blunt trauma, it's usually the result because the compression of the hollow organ caused a pop. Just think of if you squeeze a balloon, it pops, right? Well, same thing. You squeeze an intestines, it pops. The problem here is that if it pops, if it's open, the contents are going to leak into the abdominal cavity. And as they leak, they start to kind of irritate the peritoneum, and you wind up having something called peritonitis, which is bad. One of the very common signs of this is that acute abdomen, that severe and diffuse tenderness, right? So unfortunately, for a bowel perforation, there is not much that we can do in the ER except kind of help them with pain control. We want to do our best to keep them hemodynamically stable, get them ready for the OR, give them the blood they need, keep them calm, get them to the OR. These guys need to go up. If it's a severe perforation, you're going to know it, and you're going to get them to the OR. I want to take a second to talk about something that doesn't happen very often, but when it does, you're going to know it, and that's abdominal compartment syndrome. So why does this happen? Well, abdominal compartment syndrome, it's basically a buildup of fluid in the belly. It's usually associated with blunt trauma. And if you think about it, well, you think about your skin. The skin's pretty tough, right? So if we have enough fluid building up in our belly, well, there's only so many places it's going to go, and it's not really going to like burst through the skin, although I'm sure we've all seen those movies. But because of this, as that fluid builds up in the belly, it starts to actually crush the internal organs, the bowel, liver, kidneys. All of the abdominal organs can be affected. And unfortunately, the kind of systemic result of that is going to be lethal. So we need to open these patients up. The definitive treatment for this is you got to get them to the OR. They need a laparotomy. They got to evacuate all that fluid. And of course, you got to find the source of the bleeding and stop it. So like we've said in all our trauma lessons, guys, anatomy is super important. You got to know what's there to know what's broken, right? We talk about clotting and bleeding with abdominal injuries, specifically because of the liver. The liver's damaged, you're going to have some clotting issues. And of course, when there's the risk for severe hemorrhages and leaking of gastric contents and the digestive system kind of exploding, well, we worry about fluid and electrolyte balance, right? So some key points here. So we talked about solid and hollow organs. So I want you guys to try to think, are they bleeding or are they leaking, or both? It's kind of important. For the ones that bleed, they're going to bleed a lot, right? So we want to replace that blood, do those massive transfusion protocols. We want to remember the signs: Cullen's sign, Gray Turner, Cares. The more you know different signs, the more it's going to help you treat the injuries. You want to use all your senses here, guys, your eyes, your ears. I will say, however, please don't use your sense of taste. You and I and your patient will all thank you for that. And as always, with so many organs in the abdomen, always be thinking about what else might be injured. Think about the mechanism, think about trajectory, think about all the possible injuries that might be occurring. Once again, guys, thank you for joining me for this lesson. And as always, happy nursing.